This is a study, a paper from a study which has been running for the last 4 years, involving major surveys in China, Cambodia and Laos. And I'm presenting here a paper by my colleague, Professor Ding Shijun, on the study in China. The study was called POVILL, Poverty and Illness. It was funded by the European Commission. And it was looking at the relationship between poverty and ill health in those 3 countries that I mentioned. Our contention was that the relationship between poverty and ill health was being treated too simplistically, that the idea of catastrophic health expenditure was useful, but it by no means captured the many mechanisms by which poverty and health were linked. We tried to think of a way of capturing some of that complexity, and the survey methodology that we came up with was to take a large-scale probability sample of households in 2 poor counties in each of 2 provinces in China, Hubei and Sichuan, a total of 12,000 households. We then sent field workers to each of those households, and we tried to assess if they had experienced a major illness over the previous year. By a major illness, we meant one that had affected their livelihood, or would have affected their livelihood if they had not received assistance. Quite complicated, but we were trying to filter the experiences of the households to try to find those who'd really been damaged or could have been damaged by a serious illness. So we used the questionnaire survey to do that filtering, and we identified households that we said had been probably affected by a major illness. We then took a probability sample of 600 of those households, and we sent in 2 social scientists to do in-depth interviews with those households to track the course of their last year, to find out what implications the illness had had on their livelihoods over that year. This paper, the first major finding, which came from the 12,000 household survey, was that the populations we were dealing with, poor rural Chinese households in those 2 provinces, had a dramatically different population distribution from the one people typically think of, caused by outmigration of the working age population. We found there were dramatic outflows from each of the villages in which we were working, with 50, 60, 70, 80% of those of working age having moved out to work elsewhere, often only returning at the Spring Festival time. So we were left with a population which consisted largely of elderly people, my age and over at least, and young children. That had obviously implications both for the prevalence of illness in these villages and also for the labour supply within these communities. A lot of burden was placed on those elderly people whose children had gone to work elsewhere. So this resulted in fairly high levels of serious illness prevalence among this population. We had not counted on this, so originally we had thought that about 5% of households would be affected by serious illness. In fact, we found that more than 10% of households were so affected. We found that for the 9 most common illnesses in this population, around 8% or more than 8% of people suffered one or more of these illnesses. We also found, and we're still exploring this, that there were substantial differences between the richer households and the poorer households in terms of illness prevalences. In fact, for almost every illness, there was a substantially higher prevalence among the lowest quartile as compared to the richest quartile. You can see only in the case of diabetes was that reversed. So high prevalence rates, some indication that the poorer households. Of course, there is a 2-way effect here. We're looking at the end of a year when households have been affected by illness, so the illness may have made them poor, or it may be the poor households who live. And we explored that in the in-depth section of this study. We found that these households were spending large amounts of money on their care. We knew that inpatient expenditure was very large, so here is the inpatient expenditure ranging from around 300 yuan to around 1,700 yuan, 2,000 yuan down there. What we did was to compare that with the rather arbitrary poverty line in China. So we're looking here at the ratio of the mean expenditure of households as compared to the poverty line. So we knew these figures were going to be quite high. What we were interested in was the fact that a lot of households that were suffering chronic illness had not taken inpatient care, were also being asked to pay out fairly large amounts of money for outpatient services. The main reason here was that the NCMS, the insurance scheme which is covering rural households, then at least did not cover chronic illness for outpatient treatment at all. It was entirely geared towards inpatient treatment of illness. And we thought that was a serious problem for these households. Looking at that in a slightly different way, we said, well, actually there are quite a lot of households that are spending even more money on outpatient care of chronic illness. And the way we did this was to look at the cost of a single inpatient episode for one of these illnesses compared to the 75th percentile of the cost for outpatient treatment. So we were looking at towards the upper end of the distribution of expenditure on outpatient for the same illnesses. And you can see that typically where the inpatient care involves surgery, then the inpatient care vastly outweighs the outpatient care. But where it didn't involve surgery, heart disease, diabetes, and most of the other cases, the outpatient care for chronic illness at this upper end of the distribution, the 75th percentile, more or less matched the inpatient episode care. But the inpatients were getting at least partial reimbursement from the insurance scheme. The chronic sufferers who were getting outpatient care were getting no care at all. Thank you very much.